Manish mentioned molecular profiling and testing. What do you get baseline? What's reflexive? But then how does this tie into all this we've been hearing from a TCGA analysis?
Yeah, I think just two additional quick comments about staging. I think for pure gastric cancers, we also do staging laparoscopy because we identify up to 25 to 30% of patients that either have positive cytologies or frank peritoneal disease. So for gastric cancers, staging laparoscopy is indicated. Also the EUS, we sort of need, how do we apply that data? So for T1, T2 node negative tumors, they would probably go right to surgery. For T3 or node positive suggested on endoscopic ultrasound, those would be patients for neoadjuvant treatment, which we'll talk about. And certainly, excuse me, to risk stratify who gets a laparoscopy prior to treatment, it would be the T3 or node positive gastric cancers. So in terms of additional tissue studies at diagnosis, we don't really have validated molecular treatments for locally advanced disease at this point. But it's becoming increasingly common for us to do the three key tests from the outset, which would include HER2 testing, PD-L1 testing, and DNA mismatch repair protein testing. So we want to know HER2 status. We want to know whether or not the patient is MSI high or stable. And then PD-L1 testing, really more, we'll talk about the treatment of refractory disease. We'll also talk, I think, can talk a little bit about MSI as a potential prognostic factor for locally advanced disease. Those patients may actually do better. And does adjuvant treatment really contribute to MSI high tumors?
Yeah. And what about this TCGA analysis dividing the gastric cancers into 4 different?
Yeah, I think the TCGA has given us a roadmap potentially for drug development because we have identified 4 molecular subsets in gastric cancer. 50% of gastric cancers are genomically unstable, and actually about 95% of GE junction esophageal cancers fall into this category. Those are the receptor-associated tyrosine kinase amplified tumors, P53 mutation, and the less common subsets, we have genomically stable tumors, which correlate with diffuse gastric cancers, and then a small subset of the MSI high cancers and EBV-related cancers, which we see more in the stomach. There is an Asian classification that differs a little bit, where they actually make the distinction based on MSI high and stable, then P53 mutation and mutant and wild type, and then whether or not this is epithelial mesenchymal subtype, which has a particularly poor prognosis. But there is a clear acknowledgement of the importance of testing for MSI. HER2 status, really more an issue for advanced disease. We're awaiting results of adjuvant therapies directed towards HER2 positive patients, but not an issue yet.
So Kohei, in Japan, does that change? And a couple of specific questions to ask. With your HER2 testing, do you prefer immunohistochemistry to have that followed by FISH, or do you just look at FISH testing, and then do you check PD-L1 status?
So for patients with advanced stage, we can use trastuzumab for HER2-positive case, and as a consensus, this is a patient with IHC2 plus with FISH positive or IHC3 plus patient population. So in clinical practice, we just follow this protocol. That means immunohistochemistry first, followed by FISH. But recently, NGS testing is also approved in solid tumors in Japan, and will be reimbursed very soon. So more and more cancer patients underwent NGS testing if they had an advanced disease. And I want to mention the previous comment regarding the EG junction tumors. So until recently, very few patients had a GE junction tumor or esophageal adenocarcinoma, but the frequency seemed to be increasing even in Japan. Yeah. So to manage these patients are very important. And for management, we usually have 2 conferences, especially in our hospital, to discuss about esophageal tumor and gastric cancer, because procedural management is different and surgery is different. And regarding the diagnostic test, as David mentioned, staging laparoscopy is one of the very important procedures to find early peritoneal disseminations. And in Japan, we usually do it for patients with large type 3 or type 4 disease, which has a high frequency of peritoneal dissemination. And the PET scan is only done if patient has suspected metastasis.